at the Patient-Centered Primary Care Collaborative and also a member of the Board of Directors at the PCPCC. I am very pleased today to welcome all of you. I think it's 230 that are currently on the call to this talk from two of our very esteemed colleagues, Dr. Roger Kessler and Dr. Tim Burdick from Vermont. And they're going to talk about the use of health information technology in collaborative care practices, the integrated use of behavioral health in a patient-centered medical home environment. Many of you know that health IT can be a powerful integrator and tool in achieving the patient-centered medical home. Often overlooked is how the health information technology can be used to bring about collaborative care or integrative mental health and medical care. The University of Vermont and Fletcher Allen Care in Northern Vermont have really embarked on a journey to really achieve a patient-centered medical home with high integrated health information technology that does support collaborative care. And I think that's what they're here to talk about today, and we're all here to learn because I think this is a role model for health IT-driven collaborative care in this country in a patient-centered medical home. So as a brief introduction, Dr. Roger Kessler, PhD, is a clinical health psychologist in the Department of Family Medicine at the University of Vermont, and he's been tinkering around with health IT for many years around applications used for mental health, substance abuse, and health behavior. Dr. Tim Burdick, who's a family physician, practices at Berlin Family Health in Vermont, collaborates with Dr. Kessler in that practice, has also been tinkering around with health IT for quite some time. He's particularly been developing applications in their program called PRISM, and is involved with generating decision support tools and the extraction of meaningful data from a health information system, EHR. So with that, I'm going to introduce the two of them, and then when we are done, Fukan Tu, who is heading up our task force for behavioral health in the medical home here at PCPCC, will help to coordinate the group for any questions. So apologize about the delay, but with no further ado, let me turn it over to Dr. Kessler and Dr. Burdick. Gentlemen?
Good afternoon and good morning to those of you who are calling in from the morning. It is some irony that a presentation on technology has been hampered by our inability to connect to the technology, but that's apparently been resolved, with the exception of the fact that only one of us is able to be on the phone at a time. So we're going to be passing back and forward depending on the section of the presentation that we're doing. We're very excited to be rolling this out. We would hope that you would think about our presentation today as the background and methods section of a research report, to be followed at another time by the fuller set of results. So we're going to start with a bit of background, and then we're going to switch to a demonstration from our EPIC electronic health record of that which we've constructed, and then review the challenges of having done so and discuss our future, lay out a number of takeaway points, and then move on from there. So the use of technology and the attempts to generate behavioral health data in medicine is not new news. There have been many efforts, and as technology is moving forward, it's giving us a whole lot of new opportunities. If you look, part of what we know about collaborative care and behavioral health and health behavior in medicine is that collaborative care is a response to at least two major problems that have been identified in the literature. The one is access to care by patients And the second is that most mental health, substance abuse, and behavioral health behavior interventions are done in primary care. So part of the limits of the efforts historically have been that often there's been an assumption that if we can just figure out who needs the care better, i.e. do some form of information collection and screening, then we're going to do better care. Unfortunately, that position has not borne out, and it has been quite clear that unless there is a sufficient system in place to provide a response to the identification, that at the patient level care doesn't change, at the physician level physician behavior doesn't change. And that's been demonstrated amply at the end of the presentation. There are a number of citations that will summarize the literature that I was just referring to. So another reason that information in behavioral health has been difficult is there is a teachable moment, and that's the moment that a patient is in the room with a physician. Most efforts to generate behavioral health information for primary care physicians have either reached the physician post hoc, that is, even if a measure were completed prior to service, it has not been scored and gotten to the physician at the time of the care, or it's been collected post hoc, for example, in the behavioral health office subsequent to a referral. And those methods have, for lengthy periods of time, have not been particularly potent. So I have been part of a family medicine practice for some 15 to 20 years, and Tim and I practice in that same practice. And, I would say more than 10 years ago, it was clear that we needed to generate behavioral health information. But because of the multiple conundra, we have had 3 or 4 or 5 different efforts that are summarized in a paper at the end of this presentation, in which we haven't been able to accomplish the following. Rapid collection of information that isolates only those patients who need further assessment, getting further assessment data, and having that data translated rapidly into a format that's presented to the physician at the time of physician contact with the patient that allows the physician to take a set of actions, including referral to a behavioral health clinician at that moment in time, and the behavioral health clinician to have access to the same data that the physician has. Very difficult patient flow issue, practice flow issue, and technology issue. So Tim and I have been collaborating for probably 3.5 years trying to figure out how to do that. And with the advent of our EPIC-based electronic health record, which at University of Vermont is called, and Fletcher Allen is called PRISM, we saw the opportunity. We also saw, as you will discover shortly, the multiple variable layers and issues that are inherently in the path of getting it all done. So a good chunk of the last number of years has been looking at the clinical, organizational, and financial issues implicit in accomplishing being able to generate, first, a transparent electronic health record in which behavioral health and primary care have easy access to each other's record. Second, systems in place for immediate referral and scheduling for patients. And third, a way to capture information at point of contact that would be able to then translate into the next set of issues, which is ultimately data getting to the physician along with evidence-supported decision support tools. So after failing a number of times at doing this, we have refined where we are at, and we're now going to share this with you. Understand that this is a work in process. We would love to hear people's critique, ideas about how to improve it. And now I'm going to turn this over to Tim Burdick for a demonstration of our technology.
Hello, everybody. Thank you, Roger, for getting us started with the background. I'm going to cut away from the PowerPoint slides and switch over to our electronic health record. And I'm going to log in initially as a nurse in our demonstration system. There's no live patient data information in the system that we're going to be looking at today. And the workflow that we've established would initially have the patient being roomed in the primary care office by a nursing staff. And at that point, they would come into the schedule and pull up the visit with the provider. And the system's going to evaluate whether this patient has been screened for any behavioral health problems over the past 1 year. If they have not been screened, there will be an alert which will show up at the top, which will indicate that the patient is overdue for behavioral health screening. And I can talk more in a little bit, or if people have questions about the technical build that goes into designing that alert. But at that point, the nurse will jump directly into a flow sheet, which is going to prompt 4-question initial screening. If those 4 questions are negative, that is, if the patient does not have any indications on the initial 4 questions of further behavioral problems, then the screening just ends after those 4 questions. If either the PHQ-2, the initial screening for depression, or the Audit 1, an initial screening for substance or for alcohol abuse specifically, or the question for prescription misuse, if those are positive for potential problems, the system is going to pop open or cascade further questions. And so, for example, the patient will be asked by nursing staff if they have any decreased interest or pleasure in things, and the nurse can indicate that they do on more than half the days over the past couple of weeks, and they're feeling down or depressed, and likewise, they're having that a significant number of days. The system's then going to sum those 2 lines into a subtotal. And in this case, the subtotal is above a threshold cutoff. And it's going to trigger the additional questions for the full depression screen. And this additional screening goes through the same way. And I'm just going to fill these in for sake of time with some numbers. And it will then sum up the total of the initial 2 screening questions and the additional ones into a total for the PHQ-9 depression screen. You'll notice that it also opened up a GAD-2 anxiety screening. The PHQ-2 depression screening, if that's positive, not only does it trigger the additional depression screening, but it also opens up the initial 2 questions for anxiety screening. And in this case, we'll just assume that in this case, the patient isn't having a whole lot of anxiety. They do some of the time, but not enough to trigger the additional anxiety screen. If this number were higher, it would trigger an additional set of GAD screening questions for anxiety. The nurse or the MA is going to continue on and do some 2 additional screening questions. And in this case, let's assume that this patient has 4 or more drinking episodes per week. And so that's going to also pop open additional questions about alcohol screening. And the nurse or the MA who's rooming the patient will come in and fill in these additional questions as well. And just for expediency, I'm just going to fill these in. and we'll get a total for alcohol use. And we'll say in this case that the patient is negative for the screening for prescription misuse. That concludes the MA or the nurse's screening for behavioral health issues. They would then continue on with their visit, filling in a chief complaint, vital signs, and they're going to secure that encounter, close that chart up, leave the room, notify the physician or the provider, and the provider then will come in, sit down in the exam room, and they're going to log in. And when the provider logs in, they're going to open up that encounter, and they're going to be shown right off the bat some more advisories based upon those initial screenings that were entered by the nurse. It's going to give the score, so PHQ depression screen score, a total of 15. And then based upon that number, the range will trigger a very specific set of clinical decision-making rules. In this case, 15 is going to be an intermediate number. The clinical recommendation would be for brief intervention, medication, or referral for treatment. And the anxiety screen, we did, the GAD-2 was negative, so there's no indication for further evaluation for anxiety. We're going to rescreen in 1 year. The prescription misuse was negative, and the alcohol use one should be positive, and I apologize, that's not popping up. We're still in the middle of building that. There would be an additional one here for the alcohol use questions. So at this point, the provider can come into their progress notes, and if they want to document in the progress note those scores, they can pull those in. The data in the screening questions are captured as discrete fields in the electronic record, and they can pull those values in. These green sections indicate live links to other parts of the chart, and so it's pulling in the PHQ, GAD, alcohol, and prescription misuse questions directly into the primary care provider's note. At this point, there would be further discussion with the patient, and the provider can come in, and they're going to do a couple of things. They can put on here, in this case, this patient, it turns out, has some questions that make the provider think that there might be an element of bipolar, so they're going to leave the diagnosis for now as mood disorder. And because the alcohol screening was positive, they're going to add that in as well. And they'll carry those items from today's encounter over to the patient's problem list as well. And that way the behavioral health counselor who sees the patient later on in the same electronic record will find mood disorder and alcohol use in the patient's chart. And we'll see that piece again in a minute. At this point, I might decide, based upon the clinical decision alerts, that I'd like to do a referral to my colleague, Roger Kessler. Dr. Kessler will see this patient, and so I'm going to put in a referral to psychology, and I'm going to say in here that patient screen was positive for depressed mood and alcohol. And then I would like them to see Dr. Kessler. My office staff will then be able to follow that up, and there will be a formal referral tracking process that happens to make sure that that gets done as well. In addition, I can go into my schedule and not only look at my schedule, but I can come in and, because Dr. Kessler is on the same electronic record, I can look at his schedule directly, and I noticed that at 2 o'clock this afternoon, he has an opening in his schedule reserved for acute visits, and I can let the patient know if he wants to see Dr. Kessler, there's a space available this afternoon. Then there's going to be a communication piece, and there's going to be two steps to that. One is that I'm going to be able to send a message to my office staff at the checkout desk to please schedule this patient with Dr. Kessler in the 2 o'clock acute slot. When the patient goes to the checkout desk, the checkout staff will see that and be able to book the appointment directly. In addition, I'm going to have this patient follow up with me in 2 weeks, and they will get a reminder to come in to see me as well. And then the last piece is that I can actually send a copy of my note. I can CC this note directly to Dr. Kessler with a little note. Patient screen positive, has follow-up with you today at 2. And that will show up in Dr. Kessler's electronic record in his messaging section. So I'm notifying the front office staff. Patient's going to get an appointment before they leave the office today. I'm letting Dr. Kessler know as well, and keeping him in the loop. So there's communication going on between the patient, the provider, and the behavioral health specialist as well. So at this point, I've put in my my referral. I've notified the staff. I've let Dr. Kessler know, and the patient will be finishing their encounter with me, and they'll finish up with me. So the next step would be that the patient's now going to show up, and they're going to see Dr. Kessler, and when Dr. Kessler sees this patient, he will also be able to, in his progress notes, be able to pull in those same PHQ and other scores directly into his note. And those would pull in there. Of course, with the demonstration right now, those aren't pulling in for me. Those would pull in directly into his note. So he would have access to that. Now, because we're sharing the same record, he can also go in and he can see a full copy of my note in the patient's chart. And then in addition, in his in-basket, oh, I know why. I'm still logged in as me. Let me go in and log in as Dr. Kessler. Stand by for 1 second. Okay. All right. So now I'm logged in as Dr. Kessler, and stand by. Let's see. There we go. So now that I'm in as logged in as Dr. Kessler, in Dr. Kessler's basket, he's now going to get a message that I've copied a note to him. That's the message that I sent to him directly. And there'll be a message that I had indicated, Dr. Kessler, patient screen was positive, and a copy of the notes from my visit with him as well. Then when Dr. Kessler comes into the note and creates his note, he will be able to create a progress note that will pull in the items from the doc flow sheet as well. And those aren't pulling in for me. I apologize. Those would pull in there. And again, he would be able to send a note back to me, letting me know what the plan was, and we'd be able to continue our follow-up. So I'm going to pass the phone back to Dr. Kessler at this point. We'll continue going through the slides, and then at that point, if there's further questions, we can take those.
Thanks, Tim. That was excellent. I'm glad I didn't have to put all the technology of that together. Oh, that this were so simple. As I'm sure many of you out there are thinking, there are multiple issues here. Part of what we know about working in primary care is that patient flow, information demand on patient, and office flow are critical. Implicit in this work is our friends, the nurses or the physician assistants, are going to take time out of their already overloaded day to collect that data and get it in. As expeditiously as we've developed the process, it's still a workflow issue that we're struggling with. One of the okay, next. Okay. One of the things that we're now starting with the evolution of a patient data entry portal is that we are going to find ways to encourage patients in the reminder phone call that they get to go to the patient portal via the internet and to fill out the information that's needed for this visit that will be entered and be obvious in the chart so that any extra time from the rooming person will be non-existent for that patient. And, you know, it's an empirical question about how quickly and with what frequency we can get patients to think that that's a useful thing to do, although there's good data that says that these kinds of portals can be effective with different population groups. The measures and tools, we believe that we have selected best technology in the measures that has been available. You know, balancing validity of measurement and brevity of items, we've made this selection. What's the problem with the measures? Well, the biggest problem for me is that we are measuring symptoms. And as we think about patient-centered care and patient functioning, the issue really less and less is primary symptoms and more how people are functioning in their lives. And to come up with that functional measure has been an actual challenge to do so. I'm sure many of you are aware of the NIH meeting on May 1st that I do not know if one can continue to register for, which is a meeting specifically to focus on behavioral measures to be included in the EHR as part of the evolution of behavioral health and health behavior in primary care. We are still struggling with, okay, so you've got a measure, and it's indicating that you need to do something. Well, how frequently should we reassess? There's good data to say that the PHQ could be used, for example, on a weekly basis with validity to assess progress. That question comes back up. The issue of decision support, both for physicians and for behavioral health clinicians, primary care behavioral health clinicians, remains an open issue. We are constructing our program around the notion that this is an evidence-supported intervention, and that just about everything that we do in the primary care setting should have an evidence basis to it. Next, as we refine decision support, we have to make sure that it happens in real time and that the support strategies are viable. One of the interesting decision support issues is we are working as hard as we can to eliminate referrals. Well, what does that mean? We're talking about protocol, database, evidence-based, let me start that again. We're talking about data generated from the EHR, generating protocol-initiated plans for interventions. That data is generated by the panel MA within a practice, and that really defines the intervention. For example, we are working on a diabetes mellitus and obesity protocol. Well, let me hold that for a second. And say that one of the real conundrums of collaborative care is it's a good idea. We're all committed to it. But we have not done a very good job of moving past it being theory-based and experience-based. It is mostly undocumented. It is mostly unproceduralized. And it is mostly unresearched. And one of the things that we further know is you're not going to walk into a primary care clinic, as my colleague Ben Miller knows from work that we're currently doing, and being able to establish a research protocol that just easily works across multiple different clinics. NIH has an initiative out at the moment for the Kaisers and the Harvard group plans of the world that is trying to capture hundreds of thousands or millions of patients in a single database with data that is extracted from the electronic medical record. That's what we need to move towards. We need to capture the data discretely, and that's a really important element. The data that is being entered needs to be entered in discrete fields that are retrievable, not just in a free text section of a note where retrieval is that much more difficult. So the data needs to be discrete for referrals, for medications, for follow-ups, appointments, for no-show rates. Well, what happens if that's the case? Well, then we're generating a research database. Two examples is in an obesity protocol that we're working on in an internal medicine practice. BMI, a PHQ score, and the presence of either risk factors or presence of another chronic disease generates a collaborative protocol in which the behavioral health clinician has a clear role, the physician has a clear role, dietitian has a clear role, having nothing to do with any referral. Last week, SAMHSA initiated another edition of SBIRT, Screening Brief Intervention Referral and Treatment Program, in which, for the first time, they are suggesting that dollars be set aside in the application for applications of informatics in the information collecting for quality improvement and for further evaluations. So we now move on to the next slide, and I'm going to give you back to Tim, where we're talking about our takeaways thus far.
Thank you, Roger. Just one quick piece that I missed. I'm going to actually cut back quickly to our electronic health record. And in the encounters diagnoses for this visit, we can put in that this patient has had some primary care behavioral screening done currently. And the main reason for this is that, well, two reasons. Clinically and technically, it allows us to close the best practice practice behavior so that when this patient comes back in for the next visit, the computer record will recognize that this patient had screening done at that visit date. And when they come back in the next time, it's no longer going to tell the RN that the patient needs to be screened again. So it will close that off. It also allows us, for the research side and for clinical transformation, to capture the fact that the screening was done at that visit. And if there were any other interventions, we can link the fact that there were referrals or medications associated as a direct outcome of that screening process. So that finishes that up. So the integration of clinical best practices, office workflows, the technical and computer aspects, and in the future with programs such as Patient-Centered Medical Home and GPRO, PQRI, there will, we hope, be financial systems which will support this type of additional practice. It takes additional time and resources to create these systems, and without additional financial resources, it will be difficult to adopt these on a widespread basis. In addition to that, clearly there needs to be support from leadership to initiate these projects. Leadership needs to happen at the clinical level, both among physicians and medical directors at the clinics, as well as nursing and office staff leadership. For those of us who are working in larger organizations, the leadership, organizational leadership for large medical groups needs to be on board with this as well. And then the technology leadership needs to be prioritizing this in addition to the multitude of other technology initiatives underway. As you can tell just from the slides that I've showed in our electronic health record, these are complex systems. They require ongoing support, updates, and a large interdisciplinary team to get them off the ground. The regulatory requirements, CMS, et cetera, ongoing are becoming more involved around this. For those organizations who have started the meaningful use or patient-centered medical home projects, you'll recognize that this will fulfill many of the requirements around those initiatives as well. However, in addition to just responding to those requirements, this project really, we hope, will be proactive and keep us ahead clinically of those requirements as well. There's some citations from some work that has happened in the past, contact information for Dr. Kessler and for me. And I'm going to pass this back to Dr. Kessler.
So the Gilbody paper is a very thorough analysis of the last 20 years of screening and case-finding instruments, specifically to depression, but it generalizes to a lot of issues and speaks to many of the conundra. The paper that is there that I wrote is just the long, strange trip it has been paper about all the issues that I've learned about in going through this that people might consider paying attention to. And then, of course, we have the Preventive Services Task Force in 2009. And as most of you are aware, the Preventive Services Task Force has changed its recommendation slightly in the last couple of years from recommending that all adults be screened for depression to only making that recommendation if, in fact, there are systems in place for patients who screen positive to receive that which is needed for good treatment. So with that, I think I turn it back to you folks for any questions or discussion that we might have.
Okay. David, did you want me to take it from here? This is Fung Kwan. It's all yours, Fung Kwan. Okay. thank you very much to Dr. Burdick and Dr. Kessler. We do actually have some questions. Some of them are pretty simple, that housekeeping ones. People are interested in the slides and the screenshots. And would that be able to be distributed? I have the slides, but not the screenshots.
This is Dr. Burdick. Unfortunately, for proprietary reasons, the electronic health record vendor does not encourage us to share the electronic health record slides. So unfortunately, I can't make those available publicly.
Okay.
I guess that's where we are with that.
Okay, but the presentation is okay to share, correct?
Yes, the PowerPoint slides, please do share those widely.
Okay. We had a question
Before you go to the next question, Fuquan, but if folks are proximate to Vermont who want to take a trip to a reasonably nice place sometimes, I suspect that we'd be happy to sit and go through those with you in further detail.
Thank you so much, Roger. We had a question, and I'm going to say this. I wrote it to you all. What is a panel, capital M, capital A? I missed that. So I don't. But I'm not really sure how to say it. So I'm going to.
I know how to say it.
What is that? What is a panel MA? MA?
So a panel MA is cousin to a yo-yo MA. But besides that, in a patient-centered medical home model that we're using, there is an individual whose task is to essentially look at the entire patient panel who is receiving services. Patients who are on the panel who have gotten services, patients who are on the panel who haven't gotten services, patients who are exhibiting data that suggest that there are particular problems that are not under control, and that person prepares a summary of that data and shares it with the treatment team. And for the first time, at least in our practices, this whole notion of a medical problem, i.e. obesity, is now under the function of the panel manager to include behavioral health data in his look at patients with that problem, and from that identify people who are by protocol eligible for services. The problem is we just in this one practice with I think about 16,000 patients on the panel, we took a look at patients who are currently meet criterion for inclusion in the protocol, and there are over 300 patients active right now. The conundrum for us is our primary care behavioral health clinician is working at 85% volume, and we're struggling with, well, okay, we're starting to do a good job in identifying in even a finer fashion, but now how are we going to provide the services?
Okay. Do medical doctors ask the screening questions or the nurses, and is there any special training needed for this?
Ultimately, again, we hope that as we give patients internet access to information that needs to be part of them being activated patients, they will ask it themselves. In our current model, we are looking for medical assistants or nursing to being able to ask those questions. And the summary being the first thing that the physician sees when they walk in the room.
Any special training needed?
The training is in a script in how you approach sets of questions which patients have not historically been asked, but it is quite modest.
Okay. Can CMS and other insurers be billed for behavioral health assessment?
Oh boy, that's a great question. The question is, unfortunately, there's only one of us hearing this, and this is a great question. The question is, will CMS and insurers allow billing for this screening? So as you know, in President Obama's healthcare law, there is a set of covered preventative services that are to be made available to patients with no cost to them, and for which there are billing codes. CMS has recently approved a subset of those. I do not know what the active date is. No. But shortly. So my understanding is through CMS that is going to go active. And then, of course, it winds up being idiosyncratic by state. For example, Vermont Medicaid is going to support that. We're working with Vermont Blue Cross, who says that they're going to support that. But then there are 3 other insurers until we are only a single-payer system in Vermont, which hopefully will come sooner than later. So it's not going to be a blanket evolution. Yes, there's going to be idiosyncratic payment, starting with CMS. I think secondarily it'll go to Medicaid, and then it's going to have to do with the work that everybody does in their own states with people who are going to do the work to make that happen. So what Tim is just passing to me is, as of January 2011, PCP can bill for an annual preventive care behavioral screening service. The conundrum winds up being what happens if there winds up being an acute issue where you need to do screening, or it comes up in a different part than is for the annual visit, or it's initiated by a nurse or whatever. And those things have not been worked out yet.
Okay, thank you. We have a whole host of questions. I will keep going, and then we'll talk about how we can have handle the rest of the questions when time runs out. How do you all handle the confidentiality so that PCPs can see behavioral health records of their medical patients, notwithstanding HIPAA, et cetera?
Did you hear that question? So it's the straw dog of confidentiality from behavioral health records. We have vetted through insurers, through Medicare, through our regulatory people at Fletcher Allen, the issue of HIPAA and confidentiality. And we are part of the same treatment team. So behavioral health clinicians are engaged in treating the same patient that the primary care physician treats, and we have gotten the same message pretty consistently, that under HIPAA, you are part of the treating team, and no specific other action needs to be taken for confidentiality. Now, that said, of course, the issue that continues to be a quandary for all of us winds up being the lack of specificity about what the language that SAMHSA defines for substance abuse records. The differentiator used to be if you're a substance abuse program from if you are, for example, in a primary care office providing a substance abuse service and you're not a program. But the language is not totally clear, nor can total clarification be gotten, at least at our end, to totally feel comfortable yet about that.
Okay. How long on average does the medical assistance and nurse screening take? Assume a fairly positive screen and the time needed to address the cascading questions. Sorry.
Great question. Great question. I think we're talking about less than, in an area between 2 and 3 minutes, if in fact there's a negative screen. And we're talking about in the area of 3 to 7 minutes, perhaps with some populations, perhaps a population of elders who need assistance in reading or interpreting the question. It could take some longer. And, I can be flip about throwing out in 3 and 7 minutes, like, well, what's 3 and 7 minutes? It's a dilemma, and it's part of the reason that we continue to look to trying to, are we still there?
Yes.
Okay, I'm sorry. I just heard a weird sound. And that's why we're trying to come to a system in which there won't be that many times because patients are going to be using the patient portal. Now, the thing to, again, underscore, thank you, Tim, for pointing that out, is that if the data is accurate, then some 15 to 20% of the patients will screen positive. That means for 80% of the questions, the patients rather, the amount of time spent in this information collecting process will be negligible. For that other chunk of patients, the question of how is that going to effectively fit in practice flow is a very real one, and we're going to continue to be able to look at that carefully, and hopefully we'll report that back next time.
Great. This is Sung Kwan. I'm just trying to understand how much time we've gone to 2 o'clock. How do you want to handle the rest of the questions?
We had on our calendar that we were potentially live. I'm sorry?
We have till 2:30, so I think.
Oh, great, great. Hang on 1 second. Okay, I have another question. Okay, something about EPIC. Sorry about this.
Well, but even if you don't know the question, you said something very important. We work in an EPIC platform.
Yes.
That's our EHR. We are not in any way making an assumption that platform to platform to platform transferability is going to be so simple. So all we can comment on right now is, the work that we're doing within EPIC. How that work is going to translate into other EHR-based systems, I don't know.
Okay. What group in your organization do you have develop and build your doc flow sheet?
Great question. I'm going to give it back to Tim.
Yeah, can you, I'm sorry, just repeat the question again for me?
Yes. What group in your organization do you have develop and build your doc flow sheet?
The doc flow sheets are built by different people depending upon the project. In most cases, the process for this is that a clinician, usually a physician, but it could be nursing or PA, NP, some clinician will sit down with one of the members of our EHR development team. And we have a group of people, subject matter experts who work with different departments and get to know those different departments better. And they will sit down and build some specs, some specifications, kind of like a blueprint, and write those out just in Microsoft Word on a piece of paper with the design elements that they're looking for. The subject matter expert then conveys that back to an AC, or an application coordinator, who is an EPIC certified programmer, who will sit down and build it out in one of our test systems. That will then go back to the provider who put in the request, validate it, the content in our test system, and then it will be moved from the test system into our live production environment. In most cases, that's how the process works. In the case of these particular flow sheets, I've built these myself. I'm on the electronic health record team half-time, and also have the clinical knowledge and work closely with Dr. Kessler. So in this case, it was easier for me just to go ahead and build those flow sheets myself.
Okay. Do you all have recommended initial screening questions for pediatrics as well?
We've not worked on the pediatric population at this point. We're addressing the adult population currently.
Okay. And what priority do you guys use to review patient records in preparing these patient summaries?
Not sure I fully understand the question. Can you read that one more time?
What priority is used to review patient records in preparing these patient summaries? I'm reading it verbatim. I don't know if the person is still on, but I can ask them to clarify.
Okay, so what would happen is that the screening questions, those initial 4 screening questions, and let me cut back to this and see if I can pull this up. So these screening questions would happen in real time at the point of contact when the patient comes in for the office visit. And then when the provider goes in to see the patient, they will see the clinical decision recommendations. So there's not, if that's the question, I'm not sure it is, then there's no prioritization. It would happen every time the patient had the screening done. Those clinical decision recommendations would happen in real time at that visit. In terms of when the screening process happens, the screening process would be indicated once a year for each patient. Currently, we've set it up for adults. So if the patient has not had the screening done in the past year, they would get that screening done and wouldn't be prompted again until 1 year later when they came back to the office.
Okay. One of the people saying they're very enthusiastic about EMR as a tool for decision support in real time. Are you doing any work toward creating the ability for treatment guidelines to interact with real time with the specific patient's EMR? And the example given is if a PHQ screen triggers a recommendation to consider medication, is there a way at that point in time to query the patient's record to look for prior medication trials and responses, or to match system cluster to choice of med?
Great question. So and I've worked my way through this, so I'm not sure I can go back. Let me try logging back on as me as the physician here. So part of it's going to depend a little bit upon how long that patient's been a patient at our office and how long the electronic health record has been in use at any particular organization. So let's see, the screening gets done, and we've already gone through and used this patient, so I'm not sure that it's going to pop up those BPAs again. Let me see if I can jump into a different patient. See if I can get them to pull up here. Let's see. Stand by for 1 sec here. Let's see if I can do this. Yeah, so there's one of the screening questions, the clinical decision support questions that will come up, indicates the PHQ score, consider medication. So at this point, if as a physician I wanted to go ahead and consider medication, there's a couple of different ways that I could go about that. One would be to look in the patient's medication history, and I can see by going to my historical medications tab a list of all the medications that they've been on. And in this case, it looks like they've never been, at least while they've been a patient using this electronic health record system, there's no record that they've been on any behavioral health medications or psychotropics. I could do a further screening and filter down, and if they'd been on one, could find it here. So that's one way to look back historically, and if the EHR had been in use for 5 years, I would be able to track 5 years worth of past prescriptions and see if there was anything. And I could even break it down by therapeutic class, and if they'd been on one, they would be psychotropics listed as a class. So I could search for it that way. The other way to look would be to go to look at their problem list. And what many of us are doing is keeping track this way. So if they've had a mood disorder in the past, as we try different medications, we'll track those here in the comments section. And I might say, for instance, tried sertraline in 1999, had bad reaction. Did not tolerate bupropion, etc. So you could track those there, and then if they truly had a, and that would remain in that patient's chart as long as they were seen here, and it would also be seen not only by me as the PCP, but also by Dr. Kessler. So it would be helpful for him. And then if they truly had a bad reaction to something, we would probably list it on their allergies and adverse drug reaction list as well. And then if anybody did try to prescribe that in the future, they would there would be an alert that would prevent me from or recommend against prescribing again. So a couple of different ways to track things and to help with that decision making.
Okay. And then there's quite a few questions about folks that are trying to use EPIC in their system and whether they could touch base with you to kind of have some sort of expertise around how you, hang on, let me see if I can do this, expertise around how you kind of built in that technology.
Yeah, certainly. My email address is there at the bottom. Hopefully people can see that, but timothy.burdick, B-U-R-D-I-C-K, at VT for Vermont, mednet.org. And people can email me. I will also be at the EPIC Users Group meeting coming up in the fall, and if people wanted to meet up out there, if people are going out, I'd be more than happy to meet with people. And then as Roger has already extended the invitation for people to come up and visit Vermont sometime during the summer or fall foliage season, I'd be happy to sit down as well. And if need be, I can also have people speak with the AC, the application coordinator, the programmers who have helped me out. There's a couple of pieces of the best practice alerts, BPA pieces where the build is a little bit foreign to me, but for the most part, I'm pretty heavily involved with the technical side of it and would be more than glad to help people out with that.
Hey, Kwan and Dr. Burdick, this is Dr. Nays.
Yes.
Great.
Hey, I thought that was a great question, a few questions back about, and I think you commented that you can only speak to your work within EPIC. But it was a great question around, integration with other systems. And as you all know, the Accountable Care Organization Act, the proposed regulations recently came out. There's a lot of interest in health information exchange and how do systems talk to each other, because as there is more collaborative care in the broader sense, collaboration between different entities in an environment, this issue of being able to look across systems, interact across systems, regardless of platform, is so critical. And I know you can't speak to other than the system that you're currently using, but do you have any just general views of how that might be approached, or what have you heard in terms of what people are trying to work on? Certainly we deal a lot with that kind of work in the Center for eHealth.
Yeah, great question, and probably it's going to end up raising more questions than solutions at this point, or opportunities, as we like to say in the business. There's a couple of things. First of all, it's sort of the local or regional levels. Most states now are developing RIOs, Regional Health Information Organizations, and there's an opportunity there to share information across platforms with some sort of integrated database, or in some cases it's just a data exchange, a flow-through exchange for things like medications, allergies, diagnoses. So at the sort of the very most superficial level, that could potentially be helpful. If a patient is on an antidepressant being prescribed by a county mental health psychiatrist, that medication prescription would be available through the RIO data exchange back to the primary care provider and vice versa. So that's at the simplest level, and I think in many states that's starting to happen with the ONC extension centers that are being developed. Within specific platforms, Epic, for instance, there is a ability to use something called Care Everywhere that will allow different hospital organizations who are both on Epic to share information back and forth relatively seamlessly, although they maintain separate databases. Because it's on the same underlying platform, that information can be exchanged back and forth for a specific patient. Going forward, there will continue to be an increasing development of standards for diagnoses and other types of care initiatives, specifically around chronic care or chronic disease management. But I think we're still in the several years away kind of stage before we see a whole lot of that. Many of the EHRs, particularly the larger ones, will allow similar functionality with the capture of flow sheet data as discrete and measurable values, patient portals, which will allow the patient to enter some of those flow sheet questions directly at home prior to the visit, and then use some clinical decision-making tools, such as the one we demonstrated, to direct clinical care at the point of contact. So the general principle is developed or developing in most EHRs. And so I think to some extent you can take the template that we have, at least for the workflow, and apply that across multiple different platforms in the broadest sense. Getting the information to flow across those different platforms is going to be something that we're not capable of doing yet.
I think that's a great point. We recently held a small meeting sponsored by the Center for eHealth at DCPCC with Steve Waldron of the American Academy of Family Physicians and Michael Barr of the American College of Physicians and consumer groups, and we, along with some other technology vendors, and we were looking at really trying to get rid of these terms that are becoming less useful with the technology explosion. EHR and registry and HIE. What does it mean versus the RIO and the new non-RIO exchanges? So the concept, one of the things that we noted were a movement toward, just like the financial system did years ago, the more administrative consumer applications, like scheduling appointments online, collecting that initial intake information online. Maybe an opportunity to start to get this screening collection of information prior to appointment. Just the point I want to bring up, because many of those systems aren't traditionally thought of coupled with the traditional EHR. They're more on the revenue cycle side of the technologies that are out there. So there's an interesting change in the technology, and I think the experience that you've shown around how to integrate the behavioral health and the medical within the medical home is critical learning as we think about these new technologies and how they engage with the consumer and how they begin to look across technology. So great presentation.
Great. Thank you so much, David, for asking that question and comments. Can you guys handle a few more questions? They're coming fast and furious. There's one that says the ability to quickly look at the availability of a behavioral health colleague is great. Do you keep a certain number of visits frozen for acute same-day behavioral health visits due to historical knowledge, so less referral is necessary at a later date?
Sort of. Life interferes with great planning, and try to have one slot in each session available for acutes, and that works 50 to 60% of the time, and the other amount of time, because the slot is open, the front desk will kind of fill it. As I understand that, because our schedules are tight, it's hard to get in to see people. But it's supposed to be, those slots are supposed to be left open for physicians to make a decision to fill. And we have to do better work on that.
Okay. Then there's a couple of questions around what other screeners does your model utilize other than PHQ-29 audit and RX misuse. I know Paul Block was on the line, and he was asking about, do you have any sort of screens for health behaviors? So just the general question, what other things does your model utilize?
It's a great question. When I first approached Tim and the PRISM developers about being able to put placeholders on fields within EPIC for behavioral health questions, I finagled 4 questions and struggled a lot with what should the measures be. So I look at the questions that we're asking right now as placeholders. Some of them may stay, some of them may not stay, but the question is exactly on target. Health behavior and something about overall functioning is crucial, either in addition to or instead of, and we're not there yet, but we have every intention of getting there soon, which is part of the reason why I'm involved in that NIH meeting on May 1st.
Okay, I think this is a leading question, but I'll ask it. Are you a medical home certified practice?
Well, that's a very interesting question. How many 3s do we have? Just this, Ricky? Or just 1 or 2? So our patient-centered medical home pilot is a level 3. Every practice in our medical group, primary care practice, has applied, and everybody is, I believe, at. I'm not being accurate. Most folks are at least level 2, and it is high on our list for everybody to get to level 3 shortly. But from another data set, what's interesting is, Fuquan knows about this project in which we surveyed patient-centered medical homes about what are they doing about health behavior and behavioral health. It doesn't appear that that level is terribly well involved with how sophisticated the response to behavioral health issues are.
Okay. A question again, how are you able to use the internet for patient questions and communications and still protect the sensitive information from others?
That's a great question, and again, I'm going to give that back to Tim as soon as I tell him. The question is, when we get to patient portal and are using some net-based solution to collect information, how is, I think I know the answer to it, but how is confidentiality using the internet being assured?
That's a great question. So we will be starting May 15th with the EPIC version of patient portal called MyChart. There's a number of ways which we are setting various security settings to protect that information. The first is that the access process involves the patient being given a computer-generated access code, which only they would have. They would then go to a website, encrypted, log in, create a permanent login, username and password, which would then permit only them to have access to their medical information available through the patient portal. We are not initially going to be moving any physician nodes, consult nodes, progress nodes into the patient portal for various reasons. The lab results, pathology reports, etc., are set up with different levels of restriction to keep some information from crossing over that could potentially be sensitive. and that is structured mostly around psychiatry visits and diagnoses that would be generated at a psychiatry visit, such as substance abuse treatment, as well as around minors and certain diagnoses or lab tests that might be done for minors, such as protected sexually transmitted disease screening. And so there's a whole separate set of issues around parental access to minors charts that is somewhat tangential to today's conversation. So that's the major way that we're setting that up. If patients do want to allow somebody else, a spouse, a guardian, to have access to their information in the patient portal, the patient has to give written permission to allow them, and then the patient can also go in and at a fairly granular level also restrict even further what information that proxy person would have access to see. So there's the level of information that the healthcare organization pushes over into the patient's portal, and then there's another level where the patient can restrict what would go over to a proxy who would be viewing that information as well.
Okay. Hang on 1 second. Can you hang on 1 second?
Yep.
As luck would have it, my husband ordered a computer and it showed up and I have to sign for it, but I'm going to ask you the next question. We have a clarification from the person who asked about the priority used to review patient records.
Oh, good.
So the question is, my question is in follow-up to the process of having a staff person review all patient records from a data perspective to identify possibly gaps in care, with the example of an obese patient whose obesity is not being addressed.
So I think this gets to the panel medical assistant or the panel manager, who would be reviewing charts on some sort of scheduled basis. And there's a couple of different ways to prioritize how that process happens. One is just at a protocol level, we would set up certain clinical expectations that this person would be reviewing charts on patients with one or more medical comorbidities, knowing that statistically those patients are going to be at higher risk for undiagnosed or undertreated medical and included in that behavioral health problems. So that's just at the protocol level. Then in the technology side, we can also generate reports through the database and put those out in an Excel spreadsheet that will give a list of all the patients that meet certain clinical criteria. So we can generate a list of all of the patients at Berlin Family Health who have had blood pressures that are above 140 systolic and who have not had an office visit in the past 1 year. And so that can provide us some clinical prioritization as well to focus on those patients. The panel MA would then take that Excel spreadsheet, that report is generated at the first of every month, and they can go through and communicate with a patient, telephone call or message through their patient portal, and let them know that they need to schedule an appointment. Hello.
Hi, David, is there anything in there, any questions in here you want to continue about? Can you see the questions, Tim and Roger?
Can we see the questions?
Yeah, under the question tab, you can see it on your audio. But.
I cannot see them.
Okay, well, I mean, I think there are a few questions that were left unanswered, and I will make sure that they are all seen, and we can look at them and maybe respond to some at a later date. But I think that was terrific. So if Funquan doesn't come back in a moment, David, you want to sign us off and thank everyone?
Yeah, that's fine.
I'm sorry, I was on mute. How do people want to handle the extra questions, I guess was my question.
No problem.
Can we keep going for a few more minutes? And there was a question on whether, for people that had to drop off, whether we could post the Q&As.
Yeah.
Okay, so what is the average length of appointment for the behavioral health provider? Is the focus of the appointment in motivational interviewing or more on traditional therapy?
What a great question, and it's the core question. So our model says that our function is to promote best functioning with wherever somebody is. Our overall length of contact with people tends to be less than 4 sessions. And I will say in the first practice that we established, other than my own, we hired a traditionally trained social worker, and it has been more difficult because of other nonsensical stuff that don't even need to talk about, to start the thing with brief interventions. In subsequent practices, a lengthy visit is an anomaly other than perhaps for an intake or for a severe acute episode that may not be mental health, may be related to a medical issue. But our focus is not psychotherapeutic.
Okay. I'm going to end with this one, and then maybe we can find a way to send you the questions, and we can post the responses. What has been the response of patients, since we're the patient-centered primary care, and their families to this approach to collaborative med behavioral health care with HIT support? I thought this was a good question to end
Well,
with.
there's an A and B to that. I can more talk about, and this is not generalized response. This is the people that have made the comments known via patient satisfaction and focus groups. Patients are clearly loving the collaborative care stuff. We did a survey of all patients seen in one of the clinics and asked how much having the behavioral health clinician part of the practice influenced their decision to engage in treatment, and if behavioral health clinician were not there, how likely would it be that they would have seen somebody off-site? And there was just an overwhelming statement that at a very high level, people were people saw that the behavioral health clinician as part of the primary care clinic was a remarkable enhancement for them engaging to treatment, and that they thought, of course this is a moment in time when they're just responding to a question, that they were very unlikely to engage in treatment had they had to go off-site to specialty care. The B, the information enhancement, we don't have a lengthy enough or a large enough sample to adequately respond to that, but I can say in the few pilots that we have done of this intervention across different clinics, there have been hardly anybody who has refused to do it, and there have been multiple, at least subjective reports of the MA or the nurse coming up to either the physician or the behavioral health clinician and saying, the patient said, I've always wished that somebody would ask me these questions. I've never felt comfortable volunteering the information for a variety of reasons. And we've had virtually very, very, very little negative pushback.
Thank you so much. Over to you, Lauren and David.
Yeah, I think it's time to wrap up. I want to thank the people that have stayed on. I certainly want to thank Fuquan for assisting me with the questions, and Lauren for this wonderful webinar setup. But most importantly, I want to thank Dr. Burdick and Dr. Kessler for making this time available and really just showing us an exemplary way that one can use health information technology to achieve true collaborative care. So thank you, gentlemen. Thank you so much.
Thanks, everybody.
Thank you. And Lauren, I'll reach out to you on how to handle sort of the questions that we didn't get responded to, and also to you as well, Roger.